underway here. As you all know, I'm Kara Janis, a postdoc fellow here in the center, and with Dr. Melinda Rushing, we are co-coordinators of the CHEAR seminar. And we are just so delighted this morning to have the opportunity to have an external speaker with us, dialing in from Seattle. I'm very grateful to Dr. Opel for being an early riser this morning to join us to accommodate East Coast time zone for our seminar series. So by way of introduction, Dr. Opel is an associate professor in the Department of Pediatrics at the University of Washington School of Medicine. He is also interim director of the Truman Catt Center for Pediatric Bioethics at Seattle Children's Research Institute. As many of us are aware who have active research and interest area in vaccine policy and immunization services, Dr. Opel's research interests primarily focus on childhood vaccine delivery and policy, provider-parent communication, medical decision-making, and public health ethics. A big concentration of his work, which has been funded by the NIH since 2011, has been to identify effective vaccine communication strategies for use with parents, and he has also contributed substantially to measurement of vaccine hesitancy. So with that, I would like to turn it over to you, Dr. Opel. You should be able to go ahead and share your screen, and we look forward to hearing from you.
Yeah, thank you, Kara. Good to see everybody and appreciate the invite and being here today. I'm going to talk about sort of my empirical work on communication and its impact on vaccine behavior. And I was talking to a few folks as they joined. I'll also talk about a sort of natural experiment, as I describe myself as an armchair epidemiologist from time to time. It's an ambitious amount of stuff that I want to talk about today. So I'm going to get right into it. I do think I'll be able to have at least 10 minutes for questions at the end. So probably best for us to hold those questions till then so I can get through this. And I'll get down into the methods. So really look forward to engaging you all on this recent work that I've been doing. So I have no conflicts to disclose. And these were the objectives I sent along. I won't repeat them here, but as you look out at our sort of Glacier Peak, Vista, and North Cascades, this is the outline I'll follow, which largely mirrors those objectives. And I'm going to begin with a just brief description of concepts and definitions, because as I do this work more and more, I've come to realize that there's really been not much conceptual and definitional clarity in vaccine research and vaccine hesitancy research as of late. And I'm as guilty as the next person. I think there's been an often interchangeable use of loosely defined terms that really ought to have distinct and separable sort of meanings and constructs. And this has really created confusion among us, as well as sort of confusion in the implications of our research for policy and vaccine programs. So this is how I've been putting it together. And I've worked with Noel Brewer over the last few years. We both sit on the Vaccine Confidence Subcommittee of the National Vaccine Advisory Committee, really working to make headway on this. And Noel has done some similar work with the WHO. So if we could all sort of move together in this way, I think we would benefit the field. So vaccine attitudes really reflect how individuals think and feel about vaccination. Vaccine intentions, as many of you know, are one's motivations to get vaccinated, and vaccine behavior is what one does. Vaccine confidence, which is a very frequently used term these days, really reflects how we think and feel about vaccines. And there's an emerging consensus about how to define vaccine confidence. And this is how NVAC is going to define it: a belief that vaccines work, are safe, and are part of a trustworthy medical system. Vaccine hesitancy is an intention along with motivation and willingness. And again, vaccine hesitancy is poorly defined. There are many definitions out there, but here again is how NVAC is going to define it. And I believe there's alignment with WHO, a motivational state of being conflicted about or opposed to getting vaccinated. And then of course, vaccine behavior. And there are a lot of terms that we use for capturing that construct: refusal, acceptance, delay, uptake, and coverage. Now, this is a simplified model, of course. There's a lot of complexity here, but it does generally follow that attitude shape or inform intentions and intention shape behavior. There's a lot more we need to understand about this, like all of the factors influencing confidence and how those factors also influence intentions and behavior independent of attitudes and confidence. So a lot yet to figure out, but in general, I think we all could do better at ensuring that we're meaning and talking about the same thing in our work. Today, I'll talk about two of these broad constructs. Behavior and the Pivot with MI trial I talk about really is regarding a communication strategy and its impact on parent vaccine acceptance, so behavior. And then the natural experiment really was regarding how an environmental factor, namely the onset of the pandemic, influenced parent vaccine attitudes. So that's all I'll say about this. I'm happy to come back to it at the Q&A if need be. All right, let me get into the Pivot with MI trial. So this is a trial really that stands for this acronym, Presumptively Initiating Vaccines and Optimizing Talk with Motivational Interviewing. So it really conveys this communication strategy at the heart of this trial. So this communication strategy is two parts, encourages clinicians to use a presumptive format with all parents. I'll get into what that means in a little bit. And then for those parents who continue to refuse or express concerns after presumptively initiating the vaccine conversation, pivoting to use of motivational interviewing. And so this trial really tests the impact of this on, again, vaccine uptake by age 2. So a little bit about the two parts of this strategy and why we decided to include them and the rationale and evidence for them. So what is a presumptive format? Well, this is the format that clinicians use to initiate vaccine recommendations that really linguistically presuppose that parents will vaccinate. So it usually takes the form of a closed-ended statement or simply declaring something like she's due for several vaccines today. Now, this is different than other formats and principally what's called a participatory format, which is sort of on the opposite end of the linguistic spectrum here to initiate vaccines. Usually takes the form of an open-ended question like, how do you feel about vaccines today? So more explicitly invites parents to participate in the vaccine discussion, the participatory format. So the reason for including the presumptive format in our communication strategy is really based on now about a decade of evidence. I first identified this as one of the predominant formats clinicians used in sort of observational work where I videotaped health supervision visits where these vaccine conversations happen, and then follow that on with additional observational studies to look at how that initiation format was associated with certain vaccine behaviors, namely verbal acceptance by the parent of vaccines or verbal resistance to vaccines after the initiation format. And we found that a higher proportion of parents verbally resisted vaccine recommendations when clinicians used a participatory format versus presumptive. And this was actually also true among parents who had negative attitudes about vaccines as measured by a validated survey I developed. And there was also a lower adjusted odds of verbal vaccine acceptance by the end of the vaccine visit when a clinician used a participatory versus presumptive format. So a lot of limitations to this work given its observational, potential confounders that we couldn't account for, but at least likely suggested a signal worth pursuing moving forward. And others did do that. They did other observational work. Shea and colleagues also used sort of a audio recorded encounters to understand what formats clinicians used in the adolescent vaccine context and found really differential use. First, they found presumptive and participatory formats really predominated, but their use was different depending on the vaccine. Very few clinicians use presumptive with HPV, but did use them almost or all the time for Tdap and MCV in their study sample. And then similarly, Sturm and colleagues did a similar audio recorded study and found that presumptive format was also used infrequently with HPV vaccine discussions, but when used, the odds was sort of several-fold higher for vaccine receipt. So these observational studies and sort of some really suggested that this was worth studying further. And in an experimental way. And Noel Brewer did do that study in 2017, as many of you are aware, and using a sort of cluster randomized controlled trial design, found that use of a presumptive format to initiate the HPV vaccine discussion resulted in a 5.4% increase in HPV vaccine uptake in adolescents attending clinics randomized to sort of the arm where the clinicians received training in the presumptive format, well, what Noel called the announcement format, compared to adolescents receiving care at control clinics where clinicians received no training. Now, this was a great study in many ways because it really helped us sort of move past some of the limitations that likely were present in the observational work, and really provided sort of the first experimental evidence for the potential effect of using presumptive format. Noel didn't look at parent vaccine attitudes at baseline or adolescent vaccine attitudes at baseline to know whether there was a differential effect in use of presumptive format by parent vaccine attitudes, but nonetheless, I think first study to really lend strong support to the causal association between presumptive format and increased vaccine uptake. Now, of course, the presumptive format isn't a cure-all, right? It doesn't work with all parents. In my observational work, as you saw, 30% of parents voiced verbal resistance still when a parent or a clinician used the presumptive format. So we need to match the interventions we develop to a parent's or use to a parent's sort of motivation. And this is a difficulty by motivation matrix that many of you might be familiar with by Ken Resnikow. And it helped me visualize sort of the importance of not only the presumptive format, but also the use of an additional, more moderate intensity intervention to move others who may have sort of lower motivation along towards vaccination. So I would argue that in quadrant 4, so this is on x-axis sort of the level of effort needed for the intervention. So I would argue vaccination, well, some parents might disagree, is a simple change, low effort intervention, especially compared to all the things in our world that we consider interventions. Tracheostomy, for instance, would be complex change, high effort. And then on the y-axis, sort of low resistance up top and a high resistance or low motivation at the bottom. I think quadrant 4 represents those parents who are generally motivated to accept vaccination and may have some amount of sort of hesitancy, but all they may need is sort of a little bit of a nudge to get to the point of accepting vaccination. And this is what the presumptive format really does. It sort of sets vaccination as default by making a declarative statement. And as we understand more about behavioral economics and the heuristics we use as humans to make decisions, this really does that work for those that are generally motivated at the start. Those who are less motivated to accept vaccination likely need something more than that. And this is where motivational interviewing comes in. So first, what is MI? Many of you are likely familiar with this. It's a patient-centered framework for behavior change that helps really leverage inherent motivation for behaviors. But what's critical about MI is the goal is really to get a parent in our world of pediatrics to appreciate a motivational discrepancy between their present behavior and their desired goals, because it's this discrepancy that triggers or influences behavior change. So how would this look in the context of a vaccine conversation? So let's say a parent says, I know shots are important and all, but I'm just too worried about side effects. Well, a skilled MI clinician might respond to this statement by a parent with the following, highlighting this discrepancy that's evident here in what the parent says, and says, you want to be sure these vaccines are safe. I get that. I also hear that you appreciate that vaccines are important. Tell me more about why you think shots are important. So many of us would likely just sort of focus on what the parent's concerned about and take that and sort of engage the parents about their concerns about side effects. MI would encourage us to certainly acknowledge that parent has this concerns about vaccine safety, but highlight the fact that they also recognize that shots are important and get them to engage about that, to more appreciate this discrepancy between where they are and where we want them to be, as that might be what triggers them to move towards vaccination. Now, the evidence for MI in the vaccine context has really largely come from a group in Quebec, and his colleagues. They first did a quasi-experimental study in 2010 in which they tested the impact of an MI-based intervention delivered in the sort of newborn nursery to new parents within 24 to 48 hours of delivery. And it was quasi-experimental because they didn't really have a control arm. They didn't randomize parents to receiving the intervention. They just delivered it to certain parents and then included those that weren't even approached in sort of their control arm. And so what they did is then looked at the effect on short and long-term vaccination outcomes, found no difference in child immunization status at 3 and 5 months of age, but found some modest increases at 7, 13, 19, and 24 months of age. In 2014 and 2015, they followed up with this initial study with a pre-post study, same intervention and the same setting. This time they looked at vaccine attitudes, its impact on vaccine attitudes, as well as vaccine intentions, and found using, again, this parent attitudes about childhood vaccine survey, which I'll get to in a little bit. This is a survey I developed to understand parent attitudes, where low scores suggest positive attitudes, high score negative attitudes, and they found a reduction post versus pre in parent attitudes, so an improvement, and then improvement in the proportion of parents certain to vaccinate at 2 months of age, post versus pre. Now, a lot of methodological limitations to these studies, but again, a signal potentially worth pursuing. And so Joseph and colleagues did an experimental study soon after and didn't find an effect of a clinician communication strategy based on MI on HPV initiation rates, but their study really wasn't powered adequately to detect a difference in this outcome. And so Mandy Dempsey and Sean O'Leary and colleagues at Colorado did a more definitive experimental study, cluster randomized trial, to test the impact of use of MI in the HPV vaccine context, and did find a 9.5 percentage point increase in HPV initiation in intervention clinics trained to use MI versus control practices. So a more definitive signal that, again, there is this causal relationship between use of this communication strategy and vaccine behavior. So it was this that really helped us develop this communication strategy. And this is what the Pivot with MI strategy that we tested involved. So we encourage clinicians to start all vaccine conversations with parents by presuming that shots will be given at the visit, saying something like, today we're going to do 2 shots. And then if a parent agrees, on the bottom box there in the middle, simply move to vaccination. If the parent refuses or expresses concern, sometimes those are just simply questions or concerns that deserve a straightforward answer, and then parents will move to vaccination. Other times, they're sort of the tip of an iceberg where there's a lot of hesitancy or underneath. And so if that's the case and parent says, I'm not sure, I'm thinking I want to wait today, and after further exploration, really suggests there's a lot of hesitancy or lack of confidence there, pivoting then to using MI as a way to move them towards vaccination. So the MI sort of type that we included in this trial, or we taught clinicians, was called brief MI. And this is really just a short set or menu of techniques that follow the spirit and practice of MI and has been successfully used in other health behavior interventions. This is, in fact, the version of MI that Mandy Dempsey used in her cluster trial. And you can see the 5 MI skills we really focused on in teaching clinicians and their rationale. And each of these have really been demonstrated to be facilitative in helping patients resolve ambivalence when making behavior changes. So we were hopeful that focusing on these and getting clinicians to use them really might help parents recognize that ambivalence and move towards getting their child vaccinated. We emphasize that not all these had to be used in any one encounter if a clinician did pivot, but certainly all could be if needed. So I'm going to move now into sort of some specifics of the methods of this trial. So these were the components of the Pivot with MI training, and we utilized iterative focus groups with pediatric clinicians, not part of the overall trial, to help develop and revise this curriculum, mainly around sort of format and delivery, as the content really came from all the evidence we just reviewed. And what we came up with were sort of a three-part curriculum that began with baseline training, which involved an 18-minute web module. And I don't have time to show that to you today, but was a introductory animated module that was quite short, but just gave clinicians a short primer introduction into what this trial was about and what they would be learning. And then followed that with a 60-minute in-person training where we went to practices and spent 60 minutes with them going a little bit more in depth into the strategy, doing some role play. They would get into smaller groups and practice using this, and then we would debrief together. And following that were two refreshers sort of interspersed throughout the sort of intervention period. 3 to 6 months after the baseline trainer was the first refresher, and 9 to 12 months after the baseline was the second refresher. These could be a little bit shorter, but often ended up being 60 minutes. Encouraged clinicians to share their successes, share their barriers. We would also go more in depth into how to use this strategy in trickier clinical scenarios. And we also integrated into these trainings anonymized transcripts from encounters between Pivot with MI clinicians who are enrolled in the trial and parents, which was enabled by having a fidelity aim to this trial, where we went in and actually videotaped certain encounters to understand sort of how clinicians were doing with respect to what we were asking them to do. And so in an anonymized way, we sort of used transcripts from those encounters to just sort of show them how this is happening. And it allowed clinicians to really see themselves in sort of those transcripts and really reflect with the group about what went well, what could have gone better, and helped them articulate sort of some more personal sort of issues that they had with utilizing this as a way to just sort of engage them more and get them to understand how to integrate this better into their practice. So the way we tested this strategy was with a two-arm cluster randomized control trial design, in which the intervention arm was where we trained clinicians to use the Pivot with MI communication strategy, and the control arm were practices where clinicians were just encouraged to practice usual care. And we used cluster randomized trial because the need to train clinicians on this communication strategy and the potential of contamination if we randomized at the individual clinician level. And we conducted this in 24 primary care pediatric clinics in 2 states, Washington and Colorado, and we utilized 2 practice-based research networks to enroll these clinics, with the hope that across 2 states and through these networks, we would have a large representative sample. Now, clinics were the unit of randomization, and you know, a key issue, as many of you are aware, with cluster randomized trials, the possibility that there's covariate imbalance in practices assigned in different treatment arms. So we use this technique that my Colorado colleagues really are more accustomed to using, which is covariate constrained randomization, in an effort to minimize imbalance of several variables that might influence study outcomes. So those variables we used in this constrained randomization are there listed at the bottom of the slide. Proportion of parents with negative vaccine attitudes was one, and the number of clinicians and percent VFC eligible were another. Number of clinicians VFC eligible really were sort of surrogates for practice characteristics that might influence a practice's attention to immunization delivery. And then portion of parents with negative vaccine attitudes, we didn't want imbalance across arms on this issue. And so we utilized a 2-month sort of run into parent enrollment, where we distributed the parent attitudes of childhood vaccine survey among enrolled clinics to understand sort of baseline hesitancy or proportion of parents with negative vaccine attitudes at clinics. You can see here the results of our randomization, that we achieved balance across these variables. You can sort of see the range at each of the, or at clinics with these variables. So We had sort of a variety of clinics enrolled, with some clinics with as few as 2 providers and one with as many as 24. But percent parents with negative vaccine attitudes was balanced across both intervention and control arms, but quite a range in each. I should also say that we randomized, stratified by state, so there were 6 control and 6 intervention clinics in each state. In our primary study population, I want to spend some time on this, were English and Spanish speaking parents who were 18 years or older, had an infant less than 2 months, receiving health supervision and participating in practice, and importantly had negative vaccine attitudes. Now, this was important for us to have as a primary study population in this trial, because it's these parents with negative vaccine attitudes that were most interested in sort of achieving behavior change. And as I sort of intuited in sort of review of the evidence for these communication strategies that inform this pivot with MI communication strategy, there's not been a lot that has been done to understand differential effects of these communication strategies, presumptive format or MI, based on parent vaccine attitudes. So sort of mostly took all comers. So we were really interested in focusing on what is the impact of this strategy on those parents who at baseline have negative vaccine attitudes. And we define that as those who scored 2 or higher on the short form of the validated parent attitudes about childhood vaccine survey. You can see some examples, items from the short form of the PACV there. Now we limited inclusion criteria to those parents of infants less than 2 months because we wanted to ensure that we enrolled parents before the majority of the primary series of vaccines would be administered, and therefore parents would be exposed to the intervention. Our primary outcome was childhood immunization status. So back to that first slide, vaccine behavior, vaccine uptake. And we expressed this as percent days under immunized, and in our final analysis, it's percent days under immunized at 19 months of age. Now I've used this characterization of childhood immunization status now frequently, and I like it because it's a pretty sensitive measure of under immunization, and it counts for not just missed doses as up-to-date status would, but also delay in receipt of doses, which we know is a sort of a behavior of those parents with negative attitudes about vaccines. What I'll show you today is our interim analysis results at childhood immunization status at 8 months of age, and you can see the doses and vaccines that were included in both of these endpoints. So to get this data, so as I mentioned, we collected attitudinal data on all parents at check-in for a health supervision visit at a participating practice anytime between birth and that 2-month visit. And we allowed clinics to vary the time that they handed out the enrollment survey that fit their sort of practice style. Oftentimes it was the 2-week visit or the 1-month visit. Importantly, and I'll come back to this, we did not, the format or the method we used to distribute this enrollment survey was to integrate the survey into the sort of materials that clinics were already giving parents at check-in for these health supervision visits. And so our enrollment survey included a face sheet that said, this is a research study, you do not need to complete this, had all elements of the of sort of informed consent on the front page. And then for those parents that then read that and completed the survey, they were considered enrolled. Now that survey included the PACV items, but it was also embedded in a larger survey that included other attitudinal items about non-vaccine related care, really to just sort of mask sort of the inclusion criteria for the overall trial. But this is important to the natural experiment I'll get to in a bit, so I'll return to that later. We also included demographics in this enrollment survey. And the immunization data was from the states, both Washington and Colorado, immunization information systems, or when needed, the child's electronic health record. All right, a little bit about COVID, because this impacted all of us doing research particularly practice-based research, although all sorts of research were impacted, of course. We were able to develop the training curriculum and recruit clinics prior to COVID starting, and even got all of the baseline trainings completed in person. But several of the first and second refresher trainings had to happen or occurred after the start of the pandemic, and therefore we moved many of those to virtual, which actually worked out just fine. Parent recruitment began before the pandemic in September 2019. And because of our method of recruitment, that really didn't involve study staff to be in person at clinics enrolling parents, because it was integrated in sort of clinic materials and distributed by clinic staff. We didn't really have much impact on parent recruitment by the pandemic. We weren't restricted from going to practices due to shelter in place and all the things that were limiting research at the time, because we didn't need to be in person to recruit parents. There was a little bit of a reduction because just as we know, many parents did not go to health supervision visits due to shelter in place and other issues at the start of the pandemic. But eventually all clinics began to sort of communicate that they were prioritizing in-person visits of children less than 2, given the need to vaccinate. And so it was a very brief reduction, and because of this, we didn't really see much impact at all on our ability to recruit. There were some clinics that did need to pause recruitment and distribution of our enrollment survey because of structural issues that they needed to implement due to the pandemic, staffing and other things. So there were 6 clinics that paused for up to 12 months, but most only a few months. A bit about analysis. We used our analysis, I should say, just really examined the effect of allocation arm or study arm on child's immunization status. And again, among our primary study population of parents with baseline negative attitudes, so PAC-V scores of 2 or higher. We will do a secondary analysis where we look at effective study arm primary outcome among all parents, because remember, all parents that were handed a survey that wanted to do the study by completing the survey were enrolled, and not all of them had PAC-V scores 2 or higher. So we'll be able to do a secondary analysis to look at the effect of our study arm on all parents as well. This will be an intention to treat analysis where patients are the unit of analysis, and we're using applied mixed effects regression models with clinic site as a random effect to adjust the model for potential correlation within clinic. And when we do our main analysis at 19 months, we'll examine parent baseline demographic characteristics by study arm to identify unbalanced confounders and include those in regression analyses. We didn't do that at this interim stage, but what we did include in this interim analysis that I'll show you in a bit was adjust for baseline PAC-V score, because we saw differential proportions of parents who scored 2, 3, or 4 by study arm. There were a lower proportion of those who scored 2 in the intervention arm versus control. So this is our overall enrollment sort of results, as well as those included in our primary study population and those in this interim analysis. So overall, we had over 8,000 parents enrolled in Pivot with MI trial. Of those who had, of those 8,000 who had negative vaccine attitudes, 2 or higher on the PAC-V, were 939. You can see the distribution across intervention and control arms. And then those included in the interim analysis, because they had a child who was 8 months or older at the time of our interim analysis, is about a third of that total primary study population. And it's that 260 that I'll show you the results of here. So this is the demographics of those parents included in the interim analysis. This is sort of representative of demographics in Washington and Colorado states. Most were parents 30 or older, married, had some college or 2-year degree, and were white. And this is what we found so far. There was an 8% reduction in the mean percent days under immunized from birth to 8 months among children of parents with negative vaccine attitudes in the intervention control arm after controlling for this differential baseline PACU score. Now, this was not significant. We weren't expecting this to be significant at this point. This result may not hold. I mean, all the things that come with interim results hold true here, but it is nice to see that the direction of the effect was, as we hypothesized, a reduction in under-immunization in those in the intervention versus control arm. So I don't have more results for you, and I apologize about that because we're still waiting for the last child to turn 19 months of age, but this is the results as we have them at this point. Now, let me end, and this last part will take about 5 minutes. While we were waiting for, our population to get to the age where we could do our final analysis, we had the ability to sort of think about what else we could do with the data we collected. And given the onset of the pandemic, we decided to understand whether the pandemic has changed vaccine attitudes, because as I described, we were collecting attitudinal data among parents. And so this analysis really reflected our interest in understanding more about what we already understand regarding how perceptions of disease risk influence behavior. So we already know that uptake of vaccine that protects against the infectious disease is strongly correlated with one's perception of their susceptibility to and likelihood of illness. But what has sort of thwarted many of us who've looked into this over the years is that we've been asked this sort of logical follow-on question: do events that influence these perceptions, like outbreaks, epidemics, pandemics, affect vaccine attitudes and behavior? Assuming that, because of what I just said in the first bullet point, that we would see events like these really impact vaccine attitudes and behavior. But so far, there's inconclusive evidence, actually, whether an outbreak of a vaccine preventable disease results in increased uptake of its corresponding vaccine. I've done some work in others that have shown in some cases there is an effect, in others there's not. And there's no evidence, as far as I know, of whether an outbreak of an emerging infectious disease with no available vaccine against it yet changes attitudes towards vaccines in general. So that's really what we look to answer with our attitudinal data: evaluate the effect of the pandemic prior to the availability of the vaccine on parents' general attitudes about childhood vaccines, with the hypothesis being that it would. The probability that parents would have negative attitudes would be lower after versus before the start of the pandemic. So our primary exposure was the onset of the pandemic, which we considered to be the entire month of March. So pre-onset period was the day we started enrollment in Pivot with MI trial through the end of February, and then post-onset April through December 10th. And we stopped at December 10th because December 11th was when FDA authorized the first COVID-19 vaccine for emergency use. So we wanted to avoid confounding by the availability of a vaccine. Primary outcome was, again, proportion of parents with negative attitudes about childhood vaccines. And here's where those other attitudinal items come into play. We had a secondary outcome be the proportion of parents with negative response to a non-vaccine related attitudinal survey item. And you can see the item we chose here. This was one we didn't expect to change with the onset of the pandemic. So it really allowed us to sort of assess for secular trends or other time varying factors that affected the occurrence of parent vaccine attitudes. So as many of you know, an assumption in any natural experiment is the occurrence of the outcome would remain unchanged if it wasn't for the exposure or the onset of the pandemic. We use log binomial regression with GEE, GEE to sort of account for clustering at the clinical level. And its analysis was to assess the probability of negative vaccine attitudes or negative attitudes towards non-vaccine items, or that non-vaccine item associated with a transition from pre to post-onset time periods. And then we did a secondary analysis to calculate the average rate of parent negative vaccine attitudes across 3 pandemic time periods, which really kept the pre-onset period the same, but just separated the post-onset period into 2 distinct periods, approximate and distant period, to get more sense of how attitudes might have changed over that longer post-onset period. So we had over 4,500 parents enrolled in Pivot with MI during this study period in this analysis, and you can see the demographics there. You can see the cohort of parents enrolled before versus after the onset of the pandemic were slightly different on several variables, and we did include those variables in our regression analyses. So we found that there was an improvement in parent vaccine attitudes after versus before the onset of the pandemic. 42% lower an estimated adjusted risk of parents having negative vaccine attitudes after versus before the onset of the pandemic. And we didn't see any difference in this this non-vaccine related item after versus before the onset of the pandemic as expected, which just improved our confidence in the first finding that the observed change in vaccine attitudes was likely due to the onset of the pandemic. And in our secondary analysis, we found that this improvement in parent vaccine attitudes was really confined to this immediate post-onset proximate period. In fact, by the post-onset distant period, there was no significant difference between the average rate of negative vaccine attitudes post-onset distant versus pre-onset period. So our conclusions from this sort of analysis using Pivot with MI attitudinal data was that parent general attitudes regarding childhood vaccines really did improve after the onset of the pandemic, but this improvement was short-lived. Though this supports the hypothesis that an increase in the incidence of an infectious disease, even one with no vaccine against it, can positively influence parent vaccine attitudes. And I think that's an important takeaway. This has to be corroborated in other studies, but if it holds, I think public health campaigns can proactively harness this positive effect to do things like blunt declines in routine vaccinations that we've seen in this outbreak during future outbreaks. Of course, there's limitations to this analysis. It's a natural experiment. We can't randomize parents to pre and post. Therefore, there are likely unmeasured confounders that we aren't accounting for. We also measure attitudes, not behavior. Behavior is a more salient outcome here, but the PAC-V is predictive of vaccine behavior, so that lessens my concern there. We are using cross-sectional cohorts pre and post. It'd be stronger to use the same parent pre and post, but given this was a after the fact analysis that prevented our use of the same parent in that way. And we had a sample that was demographically representative of Colorado and Washington, but our results may not be applicable to other geographic areas. So this is, as I show you all the folks that have made this work possible and our funder, this hopefully is a sort of window not only into the sort of current work I do, but also generates some questions and issues and sort of engages you on some of the work you're doing. I'd love to take questions at this point. Thank you.
Wonderful. That was fantastic. Yeah, we'll take down the slides and open it up for questions. Or any burning questions? Otherwise, I have a few.
I have an initial question, actually, if I could.
Sure.
I'm not sure if I was supposed to raise my hand or not. So I liked how you defined vaccine hesitancy early on as sort of being conflicted about vaccines or being opposed to vaccines. That seems a bit different than like the official, like WHO SAGE advisory group on or working group on vaccine hesitancy, which defined vaccine hesitancy as like refusing vaccines or delaying them despite their access. I guess my question to you is, like, do you have thoughts on like how best to define vaccine hesitancy, especially since we've been like talking about it a lot, and there might be a difference between thinking of it in terms of intention and behavior.
Yeah, so this is an important issue, and while there's increasing consensus around the definition I presented, you're absolutely right. It's not full consensus. That the SAGE definition, I think, is the one from several years ago now, and I think there's been movement towards this one. In fact, NVAC is going to be using this one. I think WHO is, in concert with SAGE, sort of evolving in their definition of vaccine hesitancy, and have published or will soon publish the one that I presented. So it does reflect some movement and change from where we have been. But Abram, I think this is a reflection of where we're at. The field is relatively still struggling with these concepts and grappling with what they mean. And there's a lot of work to be done on the behavioral model. So I think while what I presented is where I think we're headed, I think there's going to be some movement still, and we all have to be flexible. But most of all, we just have to be clear with the definitions we're using, and so we can all be interpreting our results in the same way.
Thanks.
See two hands, Caroline. Why don't we take your question and then we'll go to David?
Sure. Thank you, Dr. Opel. That was very interesting. I had a question going back to something you talked about at the beginning of the talk when you were going over the sort of sizable difference between vaccine uptake depending on whether providers use the presumptive or the participatory approach. And my question is, presumably some proportion of parents who do consent to vaccination, in the moment using the presumptive, or because of the presumptive approach, have a degree of misgiving still about vaccination, but sort of in the moment agree to vaccinate because of the persuasiveness. And so my question is, what impact, if any, you think that sort of dissonance might have on long-term trust between vaccines and providers, or sort of future vaccine decision making?
It's a really good question. We did a study, and I'll send this to you, Caroline, where we looked, because that's a legitimate concern. Are we being a little bit too heavy-handed initially? And while parents might sort of feel compelled, even though they have some reservations, that ends up sort of with a negative effect long-term. We did a study looking at use of consistent presumptive or initiation formats over several visits, because as we know, this is a longitudinal conversation really where we have to revisit. And does sort of repeated use of presumptive or initial use of presumptive kind of lead to worsening immunization status over time? Now, we didn't do the definitive study where we looked through, age 18, but we did look at visits 2, 4, and 6, and then at immunization status at 8 months. And those who received presumptive format still were much more and significantly under-immunized than those who received participatory format at some point in that time period. Now, doesn't answer that question and concern of yours altogether. And I think it does require us to still understand more definitively how that presumptive format may influence longer-term immunization outcomes and ability to trust, feel like parents have a voice in the care of their child. All those are very important. I do think, though, that preliminary evidence suggests it doesn't have as negative effects as we may be concerned about. But here's the other thing. I think it's a lot in how we deliver the presumptive format as clinicians. Like, the more this feels presumptive, the more it's going to have that negative effect. I've been a huge proponent of the strategy where you are presumptive, but then you add this tag question at the end. So we're going to do 2 vaccines today. Sound okay? It's a small little question at the end, but is more explicitly encouraging the parent, if they have concerns, to voice them. But still wields the sort of default power that the presumptive format carries with it. So we've looked at use of that as a presumptive initiation, and that has as equivalent of effect as just simply the declarative statement. So I think a lot is also related to how we deliver this initiation format, presumptive initiation format, and how it's received.
Great. I know we're at time here with less than a minute. So for those that have to drop off, again, we thank Dr. Opel, but if Dr. Opel has a few more minutes, we'll go ahead and take one more question from David. And if there's any other time available in your schedule, we would continue to talk. Go ahead, David.
Thank you, Dr. Opel, for your talk. I do work in shared decision making, and I think it's important to acknowledge that these various forms of nudging people in certain directions is not what we think of when we talk about shared decision making. And there is this sort of the means justify the ends sort of rationale. My concern is that there's a well-established science of how to nudge people in certain directions. How does pediatrics, how does medicine in general sort of advise providers in terms of when they should use certain nudging procedures? Because they're likely, we know they use them across the board. And these, in hands of skilled individuals, these are very powerful cognitive techniques. right? I mean, that's why we buy certain products and avoid others. Could you speak to the bioethics?
It's a great set of questions. I'll do my best to kind of unpack a lot that was in there. But you're absolutely right. This is really an important element of sort of our interactions and relationships with parents. First off, I'll say I'm with you. Is shared decision-making really even the right model here to be thinking about with respect to the childhood vaccine context? We think about in shared decision-making most appropriate when there's more than one medically reasonable option, right? And so we have to ask ourselves, does that criterion fit here? I mean, my personal opinion is that we have one schedule. The evidence for that schedule is really robust. We don't have alternative schedules there. While there's some sort of inherent flexibility in the immunization schedule that we have with respect to when in any 30-day period a child gets vaccinated. So there's some flexibility there, but in general, this is not like a set of other things that we have in decisions that we face in pediatrics, where there are two ways to go about things. I mean, there's one schedule and that's the schedule we follow. So I'm pretty sure that shared decision-making really isn't the right approach here, where we really engage a family about two options and try to align parent preferences with the option they prefer while giving our input based on how we see medical benefit burden. So that said, I think shared decision-making really ought to be sort of sidelined here in the vaccine conversation. Now, that doesn't mean we don't, again, back to Carolyn's point, we barrel through the conversation, but it is sort of more of a clinician control. And I think we're justified in having this be a clinician controlled decision where empathically in all the things that we do in our relationship, we say this is what needs to be done. I mean, it's kind of like David, the kid that comes to your office with an asthma attack and his status is manic. You wouldn't engage the family on what to do. There's really one thing to do, which is probably oral steroids and albuterol, right? You're going to control that decision by recommending it, not engage the family about whether or not you do that, versus something else, because that's the standard care and that's treatment. So I think shared decision-making really is outside the context of the childhood vaccine context. Now, regarding nudges, I think you're right. Medicine is grappling with the appropriateness of nudges and how to use them and what criterion ought to be in place for us to use them justifiably. I thought about this a little bit, and I think the more confidence we have that an intervention is high benefit and low risk, I think is one criterion we ought to use to ensure is in place before we begin thinking about nudging. We can't be using these on sort of where the evidence isn't clear or the benefit risk ratio is not really highly favoring benefit. So that at minimum has to be in place. So the confidence we have in the evidence, and then the fact that the evidence suggests this is really a high benefit intervention. And of course, vaccines sort of fall into both of those criteria. And I think while there likely are other criteria we ought to sort of consider, I think at baseline, those are fulfilled by the childhood vaccines. And therefore, I think lend justifiability for us nudging in this context. So, I think about another intervention that we do often and we nudge often, and that's the newborn screen. I mean, I don't know if all y'all attend in the nursery, but when I do, I'm really just saying, so we're going to do this. I mean, this is kind of like the presumptive approach in the vaccine conversation. In part, I think that's justified by these same criteria. We know it's high benefit, low risk, and we have high confidence in those, although we might debate about some of the things being included on the newborn screen at the moment. But in general, high confidence in the benefits of screening for the routine disorder. So Another analogous situation, I think, that sort of give credence to some of these criteria that justify using nudges. But your overall question is a good one. I think there's a lot of work to be done normatively on when these are justified and how they ought to be applied.
Thank you.
Perfect. Well, I'm gonna, as the moderator, use my prerogative as the speaker to ask one last question. I'm sure if anyone has other questions, we could follow up via email with Dr. Opel. But I'm curious, Dr. Opel, if in the trial, what safeguards, or not safeguards, but what kind of adherence or fidelity strategies you put in place to monitor the delivery of these strategies. We know that there's a lot of evidence to suggest that these are effective strategies when delivered effectively. So,
Right.
I say this from the perspective of, we just piloted a vaccine counseling tool during health supervision visits at Michigan. And I think that, the training component is a super important part of this, but then monitoring how it's actually being used during the study is of equal importance, but difficult to add that extra layer of supervision to a tough task that providers have already.
Yeah, great question. We are measuring fidelity, as I sort of briefly mentioned, and we're doing that by direct observation. I mean, that's the method I've found most helpful and gives the most information, is to be in the room and videotape. And so among a proportion of enrolled parents coming to see Pivot with MI providers, and that proportion of parents are those who agree to videotaping. So what we've done is, in our enrollment survey, we had a addendum question: would you like to be contacted about additional ways to participate in this study? And those that gave us their contact information, we called, and most were agreeable. Sure, come and videotape the conversation. And again, it didn't know the true intent of the study, given how we masked the inclusion criteria. And so we were in the room and we saw how the clinicians were doing what we asked them to do. And you're right, it's and we did that from the beginning so that, as I mentioned, we could include what we were seeing and sort of deviations in our refresher trainings, and be able to engage clinicians in how to sort of rectify those deviations. But to formally assess fidelity, we have an MI scoring tool, we have a presumptive scoring tool that we're applying in a qualitative way to these transcripts from these videotapes to assess adherence to this strategy.
Great. Are you doing that just in the intervention arm or also in the arm?
So this is one of the issues that the pandemic did disrupt.
I'm sure.
Yeah, we couldn't get in to do videotaping during the pandemic, have since resumed, but our initial plan was to have, so to answer your question, no, we're only doing this in the fidelity arm, or in the intervention arm. There wasn't really a reason to look at how the conversation was going in the control arm. However, we were planning to do a sort of dummy videotape in control clinics, because we did want to measure parent satisfaction or visit experience after visits and intervention and control arms too, and we didn't want the presence of we were doing that after a videotape visit in the intervention arm, so we wanted to have a similar type of setting in the control arm to be able to measure visit experience. But that sort of got changed as the pandemic interrupted things.
Yes, we've all had to be creative. So,
yeah.
Well, this was fantastic. Again, thanks for joining us so early in the morning. Again, we speaking on behalf of the center, we really appreciate you joining us.